Well, good afternoon, folks. I hope you've had a wonderful day. We've had over 1,500 people join the sessions, which is just fantastic. And I hope you've enjoyed your global tour of health data science. We have, however, saved something very special to the last, because it's my great pleasure to introduce Tim Ferris, who's a doctor. And many of you will know he's the National Director of Transformation from NHS England and has been there since 2021. But Tim has had a very long and distinguished career looking at population health at scale in the United States. So we're going to get a new dimension today. He was previously CEO of Mass Gen and is also a professor of medicine at Harvard Medical School. And I asked myself, how could he do this? And actually, if you look up the derivative of his name, Ferris, it means man of iron, which I think is very apt for anyone who is trying to transform the NHS in today's world. So Tim, thank you for all that you do. Thank you for making time to join us today. The title of your talk is What is Plan B? And I'm delighted that you have agreed to take questions. So folks, do use the chat function to put in your questions and we'll have a Q&A at the end. So join me in welcoming Tim Ferris. Thanks, Tim.
Andrew, that was a really generous introduction, and I will try hard to live up to the expectations that you have just set. So I'll get right into it because I want to leave time for questions, and say, so obviously we face extraordinary challenges. Those challenges in our capacity to deliver the health services that are both financially sustainable and actually meet the quadruple aim of actually improving outcomes are, let's just say, from my perspective, they're actually moving in the wrong direction. Our challenges are mounting, not diminishing, and therefore that title, that provocative title, "What is Plan B?" was really about the challenge to the idea of is there any other plan besides the plan to really sort of radically transform the delivery of healthcare. And I personally, so that's where Plan B comes from. I don't know what Plan B is. I actually think we will need to transform. And then the question is, how are we going to do that? And that involves both focusing on the here and now, but you also have to understand where we're ultimately going. So as actually Immanuel Kant said, humans almost never go from point A to point B in a straight line. He called it the crooked timber of humanity. We can see our goals, but it is very challenging to pick the path that gets us there. And that there's no question to me about the path that gets us there. A critical enabler is not just data, the data infrastructure, the data enablement, the data science, but the use of that data both for immediate quality improvement purposes, more on the ground, but also very importantly for its potential to completely change the way we deliver healthcare, and that's the data science piece of it. And I'll now go through just a couple quickly how we frame the set of challenges in front of us, because you have to have some heuristics on which to hang the various initiatives. So digitize, connect, transform is one of our really tried and true frameworks. Actually, a rather surprising amount of healthcare delivery and social care delivery is not even digitized. So we've got to digitize, and so we have to have a plan to digitize in order to be able to connect and transform. On the connect, so a lot of the infrastructure exists to connect, but it is we don't have a plan for the architecture of connecting the data flows. We have constructed a lot of parallel data flows. So it's not particularly efficient. We collect a lot of information multiple times in different ways. So we are looking to be more planful in the way we organize and collect data. And then, and obviously keeping in mind all of the privacy and security concerns that go along with that. I'll come to that in a second. And then there is the transformation. The transformation is about, and of course, it's about both enabling the patient, so patients can use their phone to access their records and make transactions like renewing medications and appointments. What's interesting to me about the NHS is there are citizens of this country who can already do this. What's been fascinating is the fact that there's sort of these little pockets of ability to do this. So we've shown it can be done, and it's incredibly valued by the people who have access to it. But actually, a majority of the population doesn't yet have access to it. And so what are we doing in order to make sure that we spread innovation? I'll just call out the Health Foundation's report a few years ago showing that, there's lots of innovation and transformation going on in the NHS. It just doesn't spread very well. So I put that on us. That is important for us to make sure we can do that. I want to then turn to how I think about data and data architecture in the NHS and say that we really need a framework to move forward in, and that we have lots of competing frameworks. I'll just state for the record the one I'm using, and that is that there are 4 categories, use case types of uses of data in healthcare. And I think of these, despite the fact that it's the same data, I think of them quite distinctly because I think it is our job to manage each of these differently. And so there is direct care. And so we need to have the information for the providers, the right information to the right provider and patient at the right time. And that is one set of data architectures where the definitive information and the access to the use of that information are controlled within the direct care, the delivery of direct care. Then there is population health and care coordination. So this is where the vaccine program being an excellent example, probably the archetypal example, of where you actually need to aggregate individual identified data in order to make plans, in order to identify where you have challenges, and then systematically go after those challenges using identified data to actually operationalize the intervention to address whether it's COVID vaccines or cardiovascular disease. Just using the example of the single most important cause of preventable mortality in this country and the most important source of health disparities in this country. And so that's population health and care coordination. Then there's planning. And so planning is de-identified data. So it's, and the playpens in which you operate are highly restricted. So access is highly restricted, but you can't take the data out. So there's no opportunity to re-identify it. We have really good assets in the data planning space, but could be better. And there are some big holes in data planning that allow us, for example, we can't ultimately evaluate the effectiveness of 111, the 111 program, because we actually don't have the GP data of which many of the referrals from 111 go. And so so we have some holes in the planning data. And then last is the data for research. This is a bit more complicated and nuanced. There are different subcategories within those, but managed, to my mind, even though it's like the same data, managed quite differently. It's purposes, access, identification, all of those things managed differently. I depend on those 4 use case types to make sure that when I'm speaking with someone, we're clear about what use case type we're talking about, because it matters. The platforms, access, IG, privacy issues, it matters which use case you're talking about. And then let me just close by saying on a more, that was all sort of, I guess, systems architecture approach, but just the excitement that I have seen with on the transformation end about really exciting opportunities. So I'm a huge fan of what is referred to in the literature as ambient documentation. So this is an example of massive productivity gain. So around the world, healthcare, when digitization was introduced, actually productivity took a hit. It was harder to document on a computer than it was to scribble something on a piece of paper. So digitization is a great enabler, but we've actually our workforce has actually suffered under that. But I think actually technology is also the answer. When I look at the voice to text, how quickly voice to text and then turning text into actual organized notes, documentation. This is going to be a really powerful lever for improving the productivity of the entire clinical workforce. So I'll use that as a sort of data tech research area that will provide a ubiquitous improvement in productivity, addressing those challenges I led off with. But then I also want to make sure that there's those ubiquitous issues, but then there's the pathway specific issues. And here too, data technology is really just providing outstanding examples. And I'll just give one, and apologies to all those other hundreds that I'm not going to point out. But just 2 weeks ago, I was in Birmingham and saw a terrific AI analytics around dermatology. And you know that on the wait list, dermatology is right up there with hips and knees as having among the longest lists. But now we have technology that can basically screen out through a decision support tool lesions that don't need further follow-up. In specific clinical situations, those can screen out between 30 and 50% of all referrals to dermatology, and can be handled by dermatologists using decision support. This clearly is the future. That kind of data usage will be, that's plan A from my perspective about how we're going to address the capacity concerns. And there's an extraordinary amount of research required to get us from where we are to that point. So I'm going to stop there. Apologies, that was a bit of a whistle-stop tour, and happy to take questions.
Oh, wonderful. Thanks, Tim. So we've got a few questions coming in, but I'll take chair's privilege and get the questioning going. So you touched upon that there is great innovation, but it's very fragmented. So I think there's a phrase, the future is already here. It's just not very well distributed.
Yes.
So I guess part of that's awareness, but part of it's the not invented here syndrome. But how do we build a movement of community of mutual support and collaboration to spread innovation at scale?
Andrew, I'm so pleased that you asked that question, because I don't have an answer to that question. And honestly, it is one of the most challenging aspects of the delivery of changing the delivery of healthcare is the not invented here, because honestly, pride in your work is an asset. I love seeing the pride that of every organization that I visit has extraordinary pride in their innovations. And my question, Andrew, for this audience is, how do we develop pride in rapidly adopting other people's inventions? Because we don't have that pride right now. I go to Stanley McChrystal's book, Team of Teams. Yes, we have a team in Leeds or Newcastle or Liverpool or UCL or wherever it is. But we're also part of this bigger team, which is the NHS. And are there ways to have pride in speed of adoption? Because honestly, it's not, I don't want to be apocryphal, but the challenges that we face in delivering adequate health services are getting worse. And we have got to acknowledge that inventing everything here is each one by one is not going to get us where we need to go. That is not serving the citizens of this country. And so it's a great question. And I think we're going to need to develop a sense of pride of speed rather than like personally inventing or having one team invented. But I am all ears if your audience here has ways to address this.
Okay, well, certainly we would like to work in partnership with you to develop this team science approach, but we've got one or two more questions. We've got about another 4 minutes. So we've got a question from John Walsh. So John has had a heart attack, and he says the national population of cardiologists has tripled since he's had his heart attack, but we still need more. Do we need a different way of doing cardiology, and can medtech deliver for individual patients? Do you agree with that? And could this be true of medicine in general?
I do agree with that. I don't think it is even remotely possible to meet, for example, with cardiovascular disease being the number one killer in this country and preventable cause of mortality in this country and morbidity. More people we can't possibly meet the coming demand of the baby boom generation with more people. Like it is simply not going to happen. So we do need to find new ways. And honestly, I'll give an example. So for example, in cardiovascular disease specifically, if I were to take, again, using vaccines as the analogy here. So we discovered actually the old ways of doing things and delivering vaccines, like delivering vaccines at Boots or pharmacies. I'll just make a direct analogy here. Why can't pharmacists prescribe antihypertensives and lipid lowering? Because those two things together have a massive impact on the secondary prevention. And so we've got to think out of the box, but that requires data and technology to enable that. Now, the legal aspect, actually, pharmacists are now just able to actually prescribe. So some of the barriers are falling, but we haven't fully overcome the data barriers that would enable that to happen safely. But we do have to think creatively about, is this the only way to deliver care? And I think the answer has to be no. There are other ways of delivering care using technology and new definitions of roles and responsibility. But it does come with some change in risk, and that's one of the big challenges in change.
Yeah. Okay. And I'm going to apologize for the next question. We're going to Sheffield. Tim Chico, who fantastic talk, he says, and he says, apologies, but my NHS computer takes 10 minutes to start. Let me dictate one letter. And I know Tim Chico dictates very long letters. How do we convince policymakers that this is an area in need of investment?
Yes. So, we have a tech debt in the NHS. And it is really, really important to address that tech debt. I will just say that I do advocate for this in every opportunity with ministers that I have. I think it's important that we show that we are doing our part, because it's a iterative process of back and forth. And so the extent to which we show we can adopt the changes in ways of working that are clearly headed toward solving the problem, then that, I think, is helpful in unlocking some of the fiscal issues associated with addressing the tech debt. So there's a back and forth in all of these things, and while it is convenient for us to put it on ministers and say, hey, you're not giving us the money. We need to do our part to say that we are trustworthy partners in this process. We will do our part. We will change the way we work, and this is about getting into that dialogue where we can demonstrate that we're going to do this stuff in order for them to have the confidence that their investment will be well spent. Because honestly, I get into rooms where they say, Tim, I buy the stuff and then you don't use it, or then it, so we have to do our part.
Great. Okay, we've got 40 seconds left. So we're going to Scotland now. Lynn Laidlaw, who was presenting earlier, was fantastic. I was basically asking, you talk about team. Who is the team and what role do patients play in the team? A great question, then.
It is a great question. Patients play a really, really powerful role. In fact, the most powerful role, to the extent that we engage patients and there is no more potent opportunity for change than the patients themselves. If they are advocates, so answering the last question, if they are advocating for more and better technology for the caregivers, that is actually what the politicians respond to most. And so for example, one of a recent technology adopted at record speed throughout the NHS was Trikafta, the treatment of cystic fibrosis. Do you know why that was adopted so quickly? Is because patient advocacy groups were on top of it from the moment that the approvals were announced. And so there's no more potent force for change than the patients that we are trying to serve.
Okay, Tim, we've got questions streaming in, but we can't answer them all. We'll email them to you, though. We'll do that. But maybe Great. Nina Modi, who spoke earlier, she's one of the co-chairs of the conference. A lovely quote. She said, Tim, the UK has great pride in the NHS. One suggestion is to strengthen the pride of clinicians, managers, and administrators in the benefits that accrue from the best use of NHS data. And I think we're on call to support you in doing so. So if you're in Birmingham, we'll give you a rousing round of applause. We can't, but we will invite you next year and we will report fantastic progress within 12 months. And all power to your elbow. Thank you for all that you do.
Andrew, thank you very much for the invitation. And thank you to everyone who is listening for all that you're doing. We are facing some big challenges and we need everyone's elbow leaning in on this. So thank you.
Okay, thank you. Thank you, Tim.